Hello everyone, my name is Romulo Lucasen and I will present to you a case study regarding dyslipidemia. Dyslipidemia, or dyslipidemia, refers to abnormal concentrations of serum lipoproteins as defined by the third report of the National Cholesterol Education Program. It is a direct contributing factor in the development of coronary artery disease that claims almost 500,000 lives in a year just from heart attack alone. Lipoproteins are LDL, which is low-density lipoprotein, 60 to 70% main culprit in atherosclerotic plaque formation. HDL, which is high-density lipoprotein cholesterol, is 20 to 30% acceptors of free cholesterol, removes cholesterol from plaques. Contributing factors in lowering HDLs are smoking, drugs, beta blocker, anabolic steroids, progestational agents, elevated triglycerides, genes, overweight, obesity, and physical inactivity. Type 2 diabetes mellitus, very high carb intake, and over 60% of total energy intake. Very low density lipoprotein is triglyceride rich, approximately 10 to 15%. And IDL, which is hydrolyzed VLDL, that eventually can turn into LDL in plasma. Causes, we have one primary, which is genes or familial dyslipoproteinemias result from genetic defects that cause abnormalities in lipid metabolizing enzymes and abnormal cellular lipid receptors. Two is secondary causes of dyslipidemia include several common systemic disorders. We have diabetes, hypothyroidism, pancreatitis, renal nephrosis, as well as the use of certain medications such as diuretics, beta blockers, glucocorticoids, interferons, and antiretrovirals. Generally, total cholesterol levels should be less than 200, LDL less than 100, and even less than 70 for patients with high cardiovascular risk rate. Triglycerides, which constitutes the VLDL, has to be less than 150, and HDL has to be greater than 60. And here are the major risks for CHD exclusive to LDL levels. Risk factor: age. For male, positive risk is over 45, negative is less than 45. Female, over 55, and negative risk is less than 55. Family history: premature CHD. Negative is no family history. Cigarette smoking is a positive risk. Non-smoker is negative. Hypertension with a blood pressure over 140/90 is a positive risk, and being on antihypertensive medication. HDL cholesterol of less than 40 milligrams per deciliter is a positive risk, and over 60 is a negative risk. Presence of diabetes mellitus is a positive risk as well. So though exogenous and endogenous processes serum lipoproteins are formed, the diagram adapted from Wu and Robinson shows how each lipoprotein are synthesized and excreted in the body. The blue boxes shows how when there is an excess related to primary and secondary causes, as mentioned earlier, how LDLs eventually cause atherosclerotic plaque formation. Briefly, let's discuss atherosclerotic formation. As seen in 1 and 2, when serum LDL levels exceed 100 milligrams per deciliter, then cross the arterial wall and become embedded in the arterial lumen. LDL goes oxidation in 3 and are taken up by macrophages and form a plaque known as a fatty streak. The severity is related to the degree of inflammatory process. In 4, you'll see that these plaques are made up of foam cells, which are transformed macrophages and smooth muscles filled with cholesterol. These are the basic unit of atherosclerotic plaque. Eventually, scar tissue over the fatty plaque will form in the arterial wall. This is now called fibrous plaque. This plaque can significantly occlude the vessel and rupture and causing most acute coronary events such as in myocardial infarction and angina. What are the non-pharmacologic treatment? So one, we have dietary changes, avoidance of heavily saturated fats, plant stanol sterols 2 grams per day, increase viscous soluble fiber to 10 to 25 grams per day, total calories adjusted to maintain desirable body weight and prevent weight gain. Yes, of course, we have exercise. Number 3, decrease alcohol ingestion for men over 45 and women over 55. Garlic, caution with warfarin. Gardner et al. Evaluated the effect of dehydrated garlic, raw garlic, powdered garlic, supplement, aged garlic, supplement, or placebo, and found out that there is no statistically significant effects on LDL, HDL, triglyceride, and total cholesterol. Sobenin et al. Published a double-blinded study with time-release garlic powder tablets Alicor. Alicor treated patients of significant decrease in total cholesterol by 12.4% and LDL decreased by 16% on patient with mild hypercholesterolemia. Next is green tea extract. Animal studies have shown that green tea catechins reduce intestinal cholesterol absorption and decrease hepatic cholesterol content. In human studies, there are no significant decrease in fasting cholesterol levels yet. Gogol. This is part of the Ayurvedic medicines for treatment of obesity, acne, arthritis, neuropathic pain, and hypercholesterolemia. It is believed that gogol have antagonistic effect on farnesoid X receptor, which is bile receptor, for cholesterol and bile acid homeostasis. There is no human clinical significant studies yet. Then we have the red yeast rice. Fermentation produces 14 monocolins, which is hydroxymethylglutaril coenzyme A reductase, which is same mechanism of action of statins, and one of the monocolins is identical with lovastatin. One challenge with RYR is that it doesn't have uniform formulation. Last but not least is fish oil. Omega-3. Essential fatty acids inhibit the VLDL and triglyceride synthesis in the liver, used as adjunct to other lipid-lowering therapy for significantly elevated triglycerides over 500 milligrams per deciliter. This is contraindicated to type 2A hyperlipoproteinemia that is causes increased LDL level, increases risk of bleeding due to platelet inhibition and prolonged bleeding time. As you can see in the diagram, both exogenous and endogenous pathway are targeted to lower lipid. Number 1, niacin. Inhibition of VLDL secretion. Reported reaction is facial flushing, and that's recommended taking it at bedtime, and 30 minutes before aspirin can help alleviate the symptoms. 2, fibric acid derivatives, gemfibrozil, lopid, fenofibrate, tricor. It increases the lipolysis of triglyceride via lipoprotein lipase, associated with some GI symptoms like abdominal pain, dyspepsia, and diarrhea. Some reports as well of gallstone formation. 3, bile acid sequestrants, cholestyramine questran. It increases bile acid excretion that leads to increased cholesterol conversion to bile acid and reduction of LDL. Headache has been reported with the use of this drug along with folate deficiency. However, constipation is the major problem with this medication, so a laxative can be prescribed. 4, competitive inhibitors of HMG-CoA reductase. It blocks the synthesis of cholesterol in liver and has anti-inflammatory properties. Headache is a common adverse reaction. Myalgia has also been reported. 5. Exetim, which is Zetia. It blocks the absorption of cholesterol across intestinal border. It is not a first-line therapy and used in conjunction with a statin. Adherences is the key. Improving adherence to lipid-lowering medication is critical to achieving optimal patient outcomes and achieving quality goals. So, here are the lipid-lowering drugs. Atorvastatin, cholecystramine, we have Welchol and Colestipol. We have the dosage form, starting dose, and the maintenance dose. And you will see here the indication for atorvastatin, which is hypercholesterolemia. For Questran, we have hyperlipidemia. For Colesvelam, hyperlipidemia. So all of it for hyperlipidemia. Here are more lipid-lowering drugs: fenofibrate, fenofibratic acid, fluvastatin, gemfibrozil, lovastatin, niacin, pitivastatin, prevastatin. We have rosuvastatin and simvastatin.